Welcome to the module on Basic Life Support. Here's what we will cover in this module. We will learn about Introduction to Basic Life Support or BLS, Respiratory System, Cyanosis, Artificial Ventilation, Foreign Body Airway Obstruction or FBAO, Heart Attack Risk Factors and Cardiopulmonary Resuscitation or CPR. We will also learn about the role of volunteers in providing basic life support to victims. By the end of this module, you will be able to define causes of partial or total upper airway obstruction, demonstrate rescue breathing for adults, children and infants with and without foreign body airway obstruction, explain the cardiopulmonary resuscitation or CPR process for adults, children and infants, demonstrate to rescue cardiopulmonary resuscitation or CPR for adults and explain the role of volunteers. Basic life support and cardiopulmonary resuscitation are given to save victims from irreversible damage to brain cells. Basic life support and CPR are the processes through which a first responder make an attempt to stabilize a victim till the arrival of emergency medical services or advanced care. BLS is a level of medical care that is provided to victims suffering from life-threatening illnesses or injuries until they can be given full medical care at a hospital. It can be provided by trained medical personnel, including emergency medical technicians, paramedics, and by qualified bystanders. Let us next understand the respiratory system in humans. The respiratory system in humans is made up of 4 components. They are an airway, upper and lower, a neuromuscular system, which includes the respiratory center in the brain, respiratory muscles and the nerves that connect the two alveoli, which are tiny air sacs surrounded by capillaries and arteries, capillaries and veins. The alveoli are surrounded by capillaries. The brain sends nerve signals to muscles in the thorax and diaphragm, causing us to breathe. With each inhalation, air is carried through the airways to the alveoli in the lungs, where oxygen and carbon dioxide are exchanged. In combination with the respiratory system, the circulatory system supplies the oxygen necessary for life and eliminates carbon dioxide from the body. Let us know how to assess the breathing of an individual. To assess the presence of breathing, we follow the look, listen and feel or LLF method. Let us now learn about adequate, inadequate and absent breathing. Click each type to know more. Adequate breathing is when there is proper rise and fall of chest and abdomen with each breath. Air can be heard and felt exiting the mouth or nose. Breathing is effortless and breathing happens at an adequate rate. Inadequate breathing is when there is inadequate rise and fall of the chest and abdomen. Breathing is noisy with bubbles, rales, stridor, whistling and so on. Increased respiratory effort, cyanosis or bluish coloration of the skin, inadequate rate and altered mental status. Absent breathing is when there is no chest or abdominal movement. Air cannot be heard and felt exiting the mouth or nose. Next, let us understand what cyanosis is. Cyanosis is the bluish coloration of the skin and mucous membranes caused due to lack of oxygen in the blood and tissues. This condition can be due to the patient breathing in an environment poor in oxygen, suffering from illness or respiratory injury or airway obstruction. Cyanosis can be more easily noticed on the lips, ears and nostrils or nail beds. Head tilt, chin lift and jaw thrust are the two techniques used for opening the airway. Click each technique to know more. Head tilt, chin lift is the method of choice for opening the airway. Do not use this method if you suspect head, neck or spinal injury. Let us see the procedure of this method. Position the patient lying face up. Kneel by the patient's shoulders towards the head. Place one hand on the forehead and place the fingertips of your other hand under the bony part of the patient's jaw. Lift up the chin, supporting the jaw, and at the same time, tilt the head back as far as possible. For infants and children, place them in the sniffing position. Do not overextend. Here are some necessary precautions you need to take while doing head tilt chin lift. Always keep the patient's mouth slightly open. Use your thumb to hold down the patient's lower lip. Never dig into the soft tissue under the patient's chin. Once the airway is open, check breathing. Look, listen and feel. If the patient is not breathing, start artificial ventilation. If unable to ventilate, assume the airway is obstructed. The jaw thrust is the only maneuver recommended on an unconscious patient with suspected head, neck or spinal injury. Let us look at the process. Position the patient lying face up, kneel above the patient's head. Place your elbows next to the patient's head on the surface where the patient is lying. Place both hands on either side of the patient's head. Grasp the angle of the patient's jaw on both sides. For an infant or child, use 2 to 3 fingers. Use a lifting motion to move the jaw forward, up, with both hands. Keep the patient's mouth slightly open by using your thumbs, if needed. Reattempt if airway does not open. Reposition and reassess. If unsuccessful, consider using airway adjunct. Once the patient has an open airway, you can provide artificial ventilation for a patient breathing inadequately or not at all. There are many techniques for artificial ventilation. You should be competent in 3, listed below in the recommended order of preference: mouth-to-mask, mouth-to-barrier device and mouth-to-mouth. Let us look at the breathing rates and duration. In adults, 12 to 20 breaths per minute, in children, 15 to 30 breaths per minute, and in infants, 25 to 50 breaths per minute. Breathing rate also vary as per age. Look at the chart to know the breathing rate. Look for proper chest rise. With infants and newborns, use puffs from the mouth so as not to overventilate. Let us discuss the hazards to rescuers. Bloodborne or airborne diseases can be prevented by wearing mask, gloves, and eye protection. Use bag valve mask, BVM, or pocket mask. Hazards like chemicals spread because of exposure from a contaminated patient. Patient should be decontaminated first. Vomiting can be prevented by using one-way valve on a pocket mask or BVM. The problem of gastric distension can occur during rescue breathing, which can force some air into the patient's stomach. This can cause the stomach to become inflated or distended. This can be prevented by avoiding or minimizing gastric distension by positioning the patient's head properly and by avoiding giving ventilation that is too forceful or too quick. The volume should be limited to that which causes the chest to rise adequately. For a patient with a pulse and adequate breathing, place the patient in the recovery position. This position uses gravity to keep the airway clear, allowing fluids to drain out of the mouth instead of draining into the airway. The recovery position should be used on an unresponsive, uninjured patient who is breathing adequately. Keep the patient in that position until transportation arrives. Do not move the patient into the recovery position if you suspect trauma or C-spine, that is, cervical spine injury. Mouth-to-mask ventilation procedure uses a pocket face mask with a one-way valve to form a seal around the patient's nose and mouth. It is the preferred method because it eliminates direct contact with the patient and prevents exposure. Let us look at the procedure. Position the mask over the patient's mouth and nose, with the top part on the nose bridge and the wider section on the chin. Use your hand heels and thumbs to firmly seal the mask along its edges for a secure fit. There are two broad categories of barrier devices in mouth-to-barrier device ventilation procedure. They are masks and shields. Most have a one-way valve but have no exhalation port. The patient's exhaled air will leak out around the barrier device. Position the barrier device around the patient's mouth and nose, providing an adequate seal. Open the patient's airway using the appropriate maneuver. Deliver breaths at the appropriate rate and depth, observing chest rise and fall. Listen for patient exhalation. Let us look at the mouth-to-mouth ventilation procedure. The risk of contracting infectious diseases makes mouth-to-mouth ventilation very risky for use in the field. The decision to use this method is a personal one. Use barrier devices whenever possible. Open the patient's airway using the appropriate maneuver. Gently pinch the patient's nose closed with your thumb and index finger with the placed hand on the forehead to prevent air from escaping. Occasionally, you may encounter a patient who has undergone a laryngectomy. This person will have a stoma, a permanent opening from the trachea to the front of the neck. Perform direct mouth-to-stoma ventilation. Now, we will discuss cardiopulmonary resuscitation, that is CPR. During respiratory arrest, the heart can continue to pump for several minutes circulating oxygen. Without early intervention, respiratory arrest may lead to cardiac arrest. Once cardiac arrest occurs, circulation ceases and vital organs are deprived of oxygen. When respiratory and cardiac arrests occur together, the patient is considered clinically dead. Within 4 to 6 minutes without circulation, brain damage will begin, and after 8 to 10 minutes, the damage is irreversible. CPR involves a combination of chest compressions and artificial ventilations designed to revive a person and prevent biological death by mechanically keeping a person's heart and lungs working. Note that CPR must begin as soon as possible. Let us discuss preparing for CPR. No patient should undergo CPR until the need for resuscitation has been established by appropriate assessment. Before providing CPR, you must determine unresponsiveness, breathlessness and pulselessness. Here are the steps for CPR. Click each card to know more. Ask the patient, "Are you okay? What is your name?" Or tap the patient. If unresponsive, position the patient properly, supine with arms along the body on a firm, flat surface, or blood flow will be compromised. Ask someone else to activate when available. Check CAB. C refers to compressions. Push hard and fast on the center of the victim's chest. A refers to airway. Tilt the victim's head back and lift the chin to open the airway. B refers to breathing. Give mouth-to-mouth rescue breaths. Early chest compressions can immediately circulate oxygen that is still in the bloodstream. By changing the sequence, chest compressions are initiated sooner and the delay in ventilation should be minimal. Check pulselessness. On an adult and child, check the carotid for 5 to 10 seconds. On an infant, check brachial pulse. If you detect no pulse, begin CPR immediately. Use the look, listen and feel method to assess respirations. If the patient is not breathing, provide 2 ventilations. Use small puffs on infants. Chest compressions consist of rhythmic, repeated pressure over the lower half of the sternum. When combined with artificial ventilation, it provides enough blood circulation to sustain life. Chest compression comprises of the following steps: position the patient, expose the patient's chest, get in position, locate the xiphoid process, locate the compression site, position your hands, position your shoulders, and perform chest compressions. Click each step to know more. Must be supine on a firm, flat surface, with arms along the sides. Remove the patient's shirt or blouse, providing for patient's privacy as much as possible. Kneel close to the patient's side, with your knees about as wide apart as your shoulders. Feel the lower margin of the rib cage. Run your fingers along the rib cage to the notch where the ribs meet the sternum, in the center of the lower chest. Measure 2 finger widths from the xiphoid toward the upper chest. This is where you will rest the heel of your first hand. Put your free hand on top of the first hand. Extend or interlace your fingers. Do not rest them on the chest wall. Your shoulders should be directly over your hands. Keeping your arms straight and your elbows locked, thrust straight downwards from your shoulders. Release pressure completely after each compression. However, do not lift or move your hands, or you will lose proper position. Count as you perform compressions. Here, you can see the adult CPR summary of 8 years and older. Compression depth 5 to 6 centimeters. Compression rate 100 to 120 per minute. Each ventilation 4 to 5 seconds. Pulse location, carotid artery, 1 rescuer cycle, 30 compressions, 2 breaths, 2 rescuer cycle, 30 compressions, 2 breaths. Let us see CPR chest compressions for infants and children. Cardiac arrest in infants and children is rarely caused by heart problems. Usually, the cause is too little oxygen, hypoxia due to injuries, suffocation, smoke inhalation, etc. For this reason, you should resuscitate an infant child for 1 minute before activating the EMS system, if you are alone. Let us see the steps for CPR chest compressions for infants and children. They are: position the patient, expose the patient's chest, locate the compression site, and Perform chest compressions. Let us see each step in detail. Position of the patient must be supine on a firm, flat surface, with arms along the sides. If patient is an infant, place him or her on your forearm, using your palm to support the head. Expose the patient's chest by removing the patient's shirt or blouse. In a child, use the same location as an adult. In infants, use one finger width below an imaginary line between the nipples. For an infant, use the flat part of your middle and ring fingers to compress the sternum. For a child, use the heel of one hand. Release pressure completely after each compression. However, do not lift or move your hands, or you will lose proper position. Count as you perform the compressions. Child CPR Summary, 1 to 8 years of age, American Heart Association. Compression depth, 4 to 5 centimeters. 1/3 to 1/2 total chest depth. Compression rate, 100 to 120 per minute. Each ventilation, 3 to 5 seconds. Pulse location, carotid artery. 1 rescuer cycle, 30 compressions, 2 breaths. 2 rescuer cycle, 15 compressions, 2 breaths. Infant CPR Summary, 1 year old and under American Heart Association. Compression depth, 3 to 4 centimeters. Or 1 to 1.5 inches. 1/3 to 1/2 total chest depth. Compression rate, 100 to 120 per minute or more. Each ventilation, 3 to 5 seconds. Pulse location, brachial artery. 1 rescuer cycle, 30 compressions, 2 breaths. 2 rescuer cycle, 15 compressions, 2 breaths. Let us see some of the signs of successful CPR. Successful CPR does not mean that the patient survives, it only means that you performed it correctly. Very few patients survive if they do not receive advanced cardiac life support, ACLS. The goal of CPR is to prevent the death of cells and organs for a few crucial minutes. The patient's condition needs to be monitored throughout CPR to determine if CPR is effective. Have someone feel for a pulse during compressions. A pulse should be palpable with every compression. The chest should rise and fall with each ventilation. The pupils may begin to react normally. Patient's skin color may improve. Patient may attempt to move and try to swallow, and heartbeat may return. Let us see some of the complications caused by CPR. Even properly performed CPR can cause injuries, including fracture of the sternum and ribs, pneumothorax, hemothorax, cuts and bruises to the lungs, and lacerations to the liver. Let us see a few mistakes in performing CPR. Click each problem given to view the result caused by. Once you begin CPR, you should not interrupt for more than a few seconds to check for pulse and breathing, or to reposition yourself or the patient. In addition, you interrupt CPR to move the patient onto a stretcher, move the patient down a flight of stairs or through a hallway, loading or unloading the patient into the ambulance to allow for defibrillation or ACLS, advanced cardiac life support, measures to be initiated, and recover from physical exhaustion. Now, we will discuss foreign body airway obstruction, FBAO. Foreign body airway obstruction or FBAO is a partial or complete blockage of the breathing tubes to the lungs due to a foreign body like food, a bead or toy. The onset of respiratory distress may be sudden with cough. There is often agitation in the early stage of airway obstruction. Let us look at the causes of airway obstruction. These could be tongue, epiglottis, foreign body, tissue damage or illness. Click each to know more. The tongue falls back blocking the throat. This problem is common in unconscious patients. Tissue damage can be caused by a penetrating injury to the neck or inhalation of hot air. Epiglottis occurs when patients try to force breathe. It is also caused by allergies. Respiratory infections and certain chronic conditions like asthma or sudden infant death syndrome may cause tissue inflammation or muscular spasms and obstruct the airway. Objects such as food, ice, toys, dentures, vomitus, and liquid that remain in the upper portion of the throat or airway can cause airway obstruction. The key to successful treatment is early recognition. Suspect FBAO in any victim who suddenly stops breathing, becomes cyanotic or loses consciousness for no apparent reason. There are two types of FBAO. They are partial FBAO and complete FBAO. Click each type to know more about it. An object caught in the throat that does not totally block breathing is partial FBAO. A patient with partial obstruction may have adequate or poor air exchange. With adequate air exchange, the patient may cough forcefully, though there may be wheezing between coughs. Do not interfere with patient's attempt to clear the airway. With poor air exchange, the patient will exhibit a weak, ineffective cough, high-pitched noise while inhaling, increasing respiratory difficulty and possible cyanosis. Treat this situation as a complete airway obstruction. In case of complete FBAO, the patient is unable to speak, breathe or cough. The patient may clutch the neck with thumb and fingers. This gesture is known as the universal sign of choking. Movement of air will be absent. Let us know how to manage FBAO in adults. The method recommended for relieving FBAO with poor air exchange or complete obstruction is the abdominal thrust. It is also called Heimlich maneuver. Each individual thrust should be administered with the intent of relieving the obstruction. It may be necessary to perform several thrusts. It is possible to damage internal organs with this method. To minimize the possibility of injury, never place your hands on the xiphoid process or on the lower edges of the ribcage. Your hands should be below this area but above the navel. Let us know how to manage FBAO in children. Manage a complete airway obstruction in children the same way you would for adults. However, you should never use a blind finger sweep in children aged 1 to 8 years as well as in infants. Airway obstruction in children may also be caused by infections, such as epiglottis or croup, which produce airway edema. Suspect this condition if an infant or child has a fever with congestion, hoarseness or drooling. A patient with any of these conditions must be transported to the emergency facility. It is dangerous to the patient to attempt to relieve this form of obstruction. Let us know how to give abdominal thrusts for a responsive adult or child patient who is standing or sitting. First, determine whether there is complete obstruction or partial obstruction. Ask, "Hey, are you choking?" Position yourself behind the patient and place the thumb side of one fist on the center of the breastbone. Grasp the fist with the other hand and give up to 5 chest thrusts in rapid succession. Watch and listen for evidence that the object has been removed. The patient will begin to cough or speak if it has been removed. If the patient's airway remains obstructed, repeat the thrusts until the airway is cleared or until the patient loses responsiveness. If the patient becomes unresponsive before you are able to clear the airway obstruction, direct someone to call EMS and begin CPR. Let us now learn how to give abdominal thrusts for an unresponsive adult or child patient who is standing or sitting. First, take the appropriate BSI precautions. With the patient lying face up, that is, supine position, tap and shout to assess responsiveness. If unresponsive, alert EMS. Assess for the presence of breathing by looking, listening and feeling for air exchange. If breathing is absent or there is only gasping, assess for carotid pulse. If there is a pulse, attempt to ventilate the patient. If after 2 attempts, you are unable to achieve adequate chest rise, begin CPR. Chest thrusts can be applied for pregnant or obese responsive adult with the patient standing or sitting. Chest thrusts are to be used only with patients in the late stages of pregnancy or with the markedly obese when abdominal thrusts cannot be applied effectively. Therefore, use chest thrusts for pregnant women and fat persons. Also, the same procedure used for unresponsive adults will be followed after unresponsiveness. Let us now look at how to manage FBAO in infants. Always suspect foreign body airway obstruction in infants who demonstrate sudden onset of respiratory distress associated with gagging, coughing or wheezing. Click each tab to know more. Perform the following procedure only if the infant has a complete obstruction or partial obstruction with poor air exchange and only if you suspect a foreign object. Take appropriate BSI, that is, body substance isolation precautions. Pick up and support the infant between forearms of both arms. Rapidly deliver 5 back blows between the shoulder blades. If this fails to expel the object, proceed to the next step. Turn the infant over onto the back, keeping the head lower than the trunk, and use your thigh to support your forearm. Locate the compression site and deliver 5 chest thrusts. Continue with this sequence of back slaps and chest thrusts until the object is expelled or the infant loses responsiveness. If the infant becomes unresponsive before you can expel the object, begin CPR. In the case of unresponsive infants, take the appropriate BSI precautions. If the infant is unresponsive and breathing is absent or there is only gasping, alert EMS. If there is no pulse, begin CPR with chest compression. If there is a pulse, attempt to ventilate. If after 2 attempts, you are unable to achieve adequate chest rise, begin CPR. The chain of survival refers to the links through which the chance for survival of a patient increases once all the links are put together. Cardiopulmonary resuscitation or CPR can save the lives of victims in cardiac arrest. 2/3 of heart attack victims, due to heart disease, die outside the hospital, most within 2 hours of the onset of symptoms. Though CPR itself is not enough to save the life of a victim of heart attack, it is a vital link in the chain of survival. The 5 links in the adult out-of-hospital chain of survival are recognition of cardiac arrest and activation of the emergency response system, early CPR with an emphasis on chest compressions, rapid defibrillation, basic and advanced emergency medical services, advanced life support and post-cardiac arrest care. A strong chain of survival can improve the chances of survival and recovery for victims of cardiac arrest. The need for these interventions should not be limited to victims of heart disease. Many victims of drowning, trauma, electrocution, suffocation, airway obstruction, allergic reaction, etc. may be saved by prompt interventions. Let us discuss heart attack risk factors. An association has been found to exist between specific conditions and behaviors and the development of blood vessel disease. The risk factors concept was developed to create an awareness of these associations. Click each to know more. Family history, sex, ethnic background, age. Smoking, high blood pressure, high cholesterol, physical activity. Obesity, diabetes, excessive stress. The greater the prevalence of risk factors, the greater the likelihood of heart disease or other blood vessel disease. Let us discuss the heart and lung function and anatomy. The cardiovascular system consists of the heart, blood, arteries, capillaries and veins. The heart is a muscular organ, approximately the size of a fist, and is located in the thoracic cavity behind the sternum and between the lungs. The coronary arteries are special arteries that supply blood to the heart muscles themselves. The heart pumps blood, receiving oxygenated blood from the lungs and sending it to the body through the arteries. It also receives the oxygenated blood from the veins, pumping it to the lungs for oxygenation. One-way valves maintain blood flow direction and prevent backward flow. Let us learn about clinical and biological death. The respiratory and circulatory system are interdependent. If either one stops, the other will do the same in a very short time. The brain is the first organ to suffer the effects of lack of oxygen. Shortly after oxygen supply is cut off, brain cells begin to die, causing irreversible damage. Clinical death occurs when a patient is in respiratory arrest, not breathing, or in cardiac arrest, heart not beating. The patient has a period of 4 to 6 minutes to be resuscitated without brain damage. Clinical death can be reversed. Biological death occurs when the brain cells begin to die. Biological death cannot be reversed. One exception is cold water drowning. There have been cases of persons resuscitated after 1 hour or more following cold water drowning. In a cold environment, a person should not be considered dead until the victim's body is warmed. Let us discuss the signs of certain death. Three major signs are lividity, rigor mortis, and decomposition. Let us discuss these in detail. Lividity is the pooling of blood in the lower areas of the body. Shows as a purple to bluish color. A few hours after death, blood will settle in the lowest areas of the body due to gravity. Rigor mortis means stiffening of the body and limbs that occurs after death, usually within 4 to 10 hours. A decomposing body always produces a fetid odor. The rate of decomposition depends on a number of factors, primarily ambient temperature. Mortal wounds such as decapitation, dismemberment, incineration, severe crushing injuries, etc. are other signs of death. Only a medical doctor can pronounce a person officially dead. Let us discuss automated external defibrillation or AED. An AED is a lightweight, portable device. It delivers an electric shock through the chest to the heart when it detects an abnormal rhythm and changes the rhythm back to normal. AEDs help people who have a sudden cardiac arrest, which occurs when the heart suddenly stops beating regularly. This happens when the heart's natural electrical system doesn't work correctly. If not treated within minutes, cardiac arrest quickly leads to death. With simple audio and visual commands, AEDs are designed to be simple to use for a layperson. A certified medical first responder can use the AED. AEDs are designed to deliver an electric shock that will stimulate the heart to begin beating normally. The shock does not restart a heart that has stopped or is in arrest, but it will give the heart a chance to spontaneously re-establish an effective rhythm on its own. The entire process is called defibrillation. Let us discuss the conditions the device treats. Sudden cardiac arrest can happen to anyone, anytime without a warning. But this usually occurs in adults. Most cardiac arrests happen at home. Therefore, knowing how to activate the Emergency Medical Services (EMS) system, perform CPR and use an automated external defibrillator (AED) could help you save a life. The heart's electrical system sends out signals that tell the heart to pump blood. These signals travel through the upper chambers of the heart, called the atria, to the lower chambers, called the ventricles. When the heart is normal and healthy, these electrical signals cause the ventricles to squeeze together or contract. These contractions force blood out of the heart. The blood then circulates throughout the body. When the ventricles relax between contractions, blood flows back into the heart. The pauses that you notice between heartbeats when taking a person's pulse are the pauses between contractions. Let us now discuss the role of volunteers. Volunteers, to help responders ensure safety of victims by clearing hazards present at an incident site, to help rescuers carry injured victims, manually or with a stretcher, to help in first aid and stabilize injured victims, wait for a medic or doctor when a certain patient's condition calls for a special technique, to help medical staff maintain a basic life support system and to provide moral support. Let us quickly summarize the key learnings of this module. In this module, we have learned the given points: what is BLS, what are the components of the respiratory system, what are the techniques for opening the airway and artificial ventilation, what is foreign body airway obstruction, FBAO, what are the heart attack risk factors, what is cardiopulmonary resuscitation, CPR. Expand each to know about it. BLS stands for Basic Life Support and CPR stands for Cardiopulmonary Resuscitation, that is, to survive the brain cells in order to save victims from irreversible damage to brain cells. BLS is a level of medical care that is used for victims of life-threatening illnesses or injuries until they can be given full medical care at a hospital. The respiratory system is made up of 4 components: an airway, upper and lower. A neuromuscular system includes the respiratory center in the brain, respiratory muscles, and the nerves that connect the two. Alveoli, tiny air sacs surrounded by capillaries. Arteries, capillaries and veins. Head tilt, chin lift. This is the method of choice for opening the airway. Do not use this method if you suspect a head, neck or spinal injury. Jaw thrust. The jaw thrust is the only maneuver recommended on an unconscious patient with a suspected head, neck or spinal injury. Once the patient has an open airway, you can provide artificial ventilation. There are many techniques for artificial ventilation. You should be competent in the 3 listed below in recommended order of preference: mouth to mask, mouth to barrier device, mouth to mouth. Foreign body airway obstruction means a partial or complete blockage of the breathing tubes to the lungs due to a foreign body, for example, food, a bead, a toy, etc. The onset of respiratory distress may be sudden with a cough. There is often agitation in the early stage of airway obstruction. There are 2 types of FBAO, partial and complete. An association has been found to exist between specific conditions and behaviors and the development of blood vessel disease. The risk factors concept was developed to create an awareness on these associations. Factors that cannot be changed: family history, sex, ethnic background and age. Risk factors that can be changed: smoking, high blood pressure, high cholesterol and physical activity. Contributing factors: obesity, diabetes and excessive stress. During respiratory arrest, the heart can continue to pump for several minutes and circulate oxygen. Without early intervention, respiratory arrest may lead to cardiac arrest. Once cardiac arrest occurs, circulation ceases and vital organs are deprived of oxygen. When respiratory and cardiac arrest occur together, the patient is considered clinically dead. Within 4 to 6 minutes, brain damage will begin, and after 8 to 10 minutes, the damage is irreversible. CPR involves a combination of chest compressions and artificial ventilation designed to revive a person and prevent biological death by mechanically keeping a person's heart and lungs working. Now, it is time to check your understanding of the topic. This is an evaluation exercise. All questions are equally weighted. You need to score at least 60% to pass the test. Read the questions carefully and select the appropriate options. Congratulations!